Hello everyone, good evening. Please just let me know that the audio visual is going well, which means you can see me, you can hear me, you can see my pointer going here on the board. People watching, please just quickly let me know if the audio visual is okay, so that I can just proceed and take up this very important session on spondyloarthropathies. Okay, so audio visual I think is going well, so I think I can just quickly get started. So this is a session on spondyloarthropathies and this is part 2, because this month I had already taken part 1 where I had started up with the spondyloarthropathies. So the crux here is that I want to complete up and wrap up that part also and give you complete insight into the spondyloarthropathies. That is what the scenario here is, that I'll be pursuing from the same part, progress from the same area. But here first I'm going to just give you a quick recap about these spondyloarthropathies before I just begin with the fresh area for today. Now last time when we talked of spondyloarthropathies, I just gave you the clear insight as to what do I mean to refer to. The word spondylo basically means spine. You're very much familiar with this. The word arthro is referring to the peripheral joints, the appendicular joints, shoulder, hip, knee, hand joints, peripheral joints. So you are having involvement of the spine and the peripheral joint. That is what's meant by the word spondyloarthro. And this word pathies is degeneration in the joint, okay, which you very well understand. So you have the spine and the peripheral joints involved. But let me tell you, that's not all to call something as spondyloarthropathy. The crux of the problem has to be autoimmunity. So until unless you can document that there is an element of autoimmunity involved, you cannot call the condition as spondyloarthropathy. So these are the criteria that have to be there. You have to have multiple joints involved, which would include the central skeleton like the spine, the pelvis, which would include the peripheral joints like the hip, knee, shoulder, and even the hand joints. So that's where we'll call it spondyloarthropathy, provided you are able to find out that there is an element of autoimmunity. Now these spondyloarthropathies, as I told you, we broadly categorize them into two varieties: a seropositive spondyloarthropathy and a seronegative spondyloarthropathy. So we categorize into these two categories. Now seropositive spondyloarthropathy basically means that we know the autoantibody that is producing the damage, like rheumatoid arthritis. You are very much familiar with those autoantibodies, something that we call as a rheumatoid factor, or you are very much familiar with this particular autoantibody, the anti-cyclic citrullinated peptide antibody, anti-CCP. I think there's a small interruption that's coming up. Okay, fair enough. So I hope the things are okay now. Maybe there was a small technical error that happened, guys. But I suppose things are now okay and I am back. So I was telling you that the spondyloarthropathies, you have seropositive and you have seronegative. And in the seropositive spondyloarthropathies, you know the autoantibody like the rheumatoid factor or the anticyclic citrulinated peptide antibody. So when you are able to document these autoantibodies in the serum, that is where you say that this spondyloarthropathy is the seropositive spondyloarthropathy, which is rheumatoid arthritis. But as I told you that there are some spondyloarthropathies where the autoimmune factor is not known. They come into this category, seronegative spondyloarthropathies. Now seronegative spondyloarthropathies also, we know there is an autoimmune element involved. But we know this autoimmune element is involved because here we know that the problem that is defective in them are the human leukocyte antigens, HLAs. I think you are very much familiar now, at least after the previous session, as to what are these human leukocyte antigens. Just in case you are not clear, I will just brief this again up to you. So guys, on the short arm of chromosome 6, the P arm, you have a gene that is called the major histocompatibility complex, MHC. This major histocompatibility complex encodes for a section of proteins, because that's what a gene would do, it would code for proteins. Now the proteins that are coded by the major histocompatibility complex, they are called the human leukocyte antigens, HLAs. And the biggest thing here, this word leukocyte is a misnomer, because these are not the proteins that you find actually just on the leukocytes. They are called leukocyte antigens because they were first identified on the leukocytes. You have these proteins on all cells of the body, barring a few like the RBCs, and these are the proteins that help you with the identification of the self antigens. So as you are maturing, in your thymus gland in the neck, your T cells are being exposed to the body antigens, and they are being taught that this is our own antigen because it is carrying the HLA protein of the body. And these people, these leukocyte antigen proteins that are present on self antigens of the body become defective at some places. So body starts recognizing them as foreign proteins and start destroying its own body in the area of the joints and some other tissues. So from the defective HLA, we know that there is an element of autoimmunity. So we are calling them as seronegative spondyloarthropathies. And when we talk of seronegative spondyloarthropathy, the classical example that comes over here, ankylosing spondylitis. This part also includes psoriatic arthropathy. This part also includes what we call as reactive arthritis, and this part also includes what you call as the inflammatory bowel disease associated arthropathies. So all these conditions, what you're going to find, so there is a problem with the body human leukocyte antigens, so you know that there is an element of autoimmunity. So this is what will come under the seronegative spondyloarthropathy. So last particular session we talked of the seropositive spondyloarthropathy. So this particular session I'll be concerning more on the seronegative group. So you guys are clear with this small introduction? Into your hot seats, right, to start with me, and we go ahead and we begin the discussion. So this 35 years old female, she's come to you and she's been referred to you by a physician who was treating her for a recurrent UTI she had been getting on and off. Now she also complained of pain and swelling in the knee, and that's why she was maybe referred to you as an orthopedic surgeon. You didn't find much on the x-rays, so you got the MRI done, and all the MRI report reads is synovitis and effusion. The ESR CRP levels are little raised, although CBC is normal. This is just mild kind of anemia. There is no history of trauma per se, although she's had some water sports. But water sports, knee getting injured is again, very unlikely. Now her anti-nuclear antibody levels were done and they turned out to be positive. But mind you, no photosensitivity. So certainly not SLE. Okay, because anti-nuclear antibodies, you would generally correlate with SLE. Now you have to tell me, going through this history, that what option out of the 4 would likely relate to the diagnosis here. So mind you, this is a 2-part question. The first part, what is the diagnosis? And once you have framed the diagnosis in your mind, now you have to tell me which would be the correct choice. So guys, invitation from my side to you, please come out. What is the likely answer here and what is the likely diagnosis? Anything you wish to let me know, anyway you wish to let me know this answer. So what do you think is the diagnosis and what do you think will be the correct answer? So you guys are invited to put that up in the chat box. So please move ahead and put that up in the chat box. Again telling you, young female, she's had UTI, but after UTI problems in the knee, inflammatory markers are raised, so something wrong with the immunity part. The ANA levels are positive, though photosensitivity is there. So what do you think seems to be the likely diagnosis? Quickly, some hints you can let me know on the diagnosis, and if you can just let me know which of the following is going to be the correct statement. If you go with the RA factor, will it be positive? Or will actually B27 be positive in this patient? Or will that anemia that she is having is going to be macrocytic megaloblastic? Or would these ANA titers that are positive can simply guide you to the prognosis? Wonderful, Ritesh. So you've cracked it up absolutely well. So this is actually that case of reactive arthritis. Perfect, full marks. So what basically happens in reactive arthritis? That you get some kind of a infection like UTI, and now auto antibodies develop because of this UTI. So antibodies developed to the UTI organism, but they reacted against the body because the body's immunity was faulty, because the HLA B27 was defective. Now they reacted against the body and these inflammatory markers were raised, and you started getting damage to the knee joint. So knee started having pain. Got it? So this is reactive arthritis. That's an HLA B27 related arthropathy. So that is what you can find to be positive. Mind you, sometimes these people with reactive arthritis can also have conjunctivitis and urethritis. So in this lady, you already have reactive arthritis, you already have urethritis, only conjunctivitis is missing. If someday this lady also complains of eye symptoms, then you will have to change your diagnosis a little bit, because that is the stage where this lady will now become a case of Ritter syndrome. So Ritter syndrome is just when you have this triad of reactive arthritis plus conjunctivitis plus urethritis. So I hope you guys are thoroughly clear with this particular scenario. A case of seronegative spondyloarthropathy, multiple joints can be involved. Maybe knee is the starting point here, because most commonly when you talk of reactive arthritis, where it starts with is the knee joint. But then other joints can definitely be involved if you don't control it by giving the right kind of treatment. So perfect enough, full marks onto you, Ritesh, at least for this one. Okay, now this particular question, I don't think I need to speak to you the diagnosis here. Everything is given in the question very nicely. 65-year-old male, he's come to you with a history of back pain that's been there since 3 months. His ESR CRP levels are raised and he has sacroiliac joint tenderness, the golden point. So I think good enough to tell you from this history that what this examiner is talking of is about this condition, ankylosing spondylitis. Perfect enough. Wonderful, I know. So Ritesh, you're absolutely right that this is actually a case of ankylosing spondylitis, and reading the history, this is ankylosing spondylitis because the sacroiliac joint has been involved. So I want you now to help me out with the incorrect choice here. You do the modified Schober's test, you find the excursion to be more than 10 centimeters, this is incorrect. Or will the MRI be showing spondylodiscitis? This is incorrect concerning ankylosing spondylitis. Or if you ask this patient to stand against a wall, he'll find it difficult to touch the head and the buttocks simultaneously. This is incorrect. Or treatment should be with the anti-TNF drugs, tumor necrosis factor alpha drugs, infliximab, etanercept. This is incorrect. So guys, please submit your choices. No problem in my class with negative marking, because I simply tell you a mistake here would be a memory. So feel free to submit your choices. So quickly help me out, Ritesh. Please pour in with your comments also, fully invited, and all people watching. Please feel free to communicate. I always say no negative marking in my class. A mistake here is just a memory. So feel free to let me know. This man with raised ESR-CRP level, the sacroiliac joint tenderness, seems to be a case of ankylosing spondylitis. So in a simple way, all I want to let you guys answer here, that which of the following is not going to be the correct option here. Okay, Nishtha says C, so there's a vote here for choice C. Ritesh has written the answer with a question mark as if he's also a little unsure. So he says choice A, and more people can participate. Because your participation keeps me also going. Okay, so people watching, please feel free to leave your comments so that I can finally decide upon the balanced answer, because sometimes I may also be incorrect. You may put in the right correction to me. Okay, so I'll tell you my answer here. I would go with what Ritesh has said, choice A. Fairly sensible enough, because let me tell you, the excursion here will not be more than 10 centimeters. It will be less than 10 centimeters. So in fact, all you need to be clear about here is how you do the Schober's test. But before that, let me just tell you how other options they are correct. See, first of all, this is an inflammatory arthropathy that needs a bit of understanding, because it's a little different from others. Undoubtedly, this is again an inflammatory arthropathy that's associated with actually B27. So actually B27 is definitely positive, and it's in fact positive in like 90 to 95% of the patients who have ankylosing spondylitis. So this is one inflammatory arthropathy where you can just convincingly say that if this patient is actually B27 positive, he has ankylosing spondylitis, because the association with HLA is the highest, strongest. Now about this inflammatory arthropathy, I would just like to let you know what is very different from other inflammatory arthropathies is the pattern of involvement. Very different. The first thing, that this inflammatory arthropathy classically tends to have a predilection for the axial skeleton, central skeleton. So classically what you find is the central skeleton involved. So this is where the problem starts, sacroiliac joints, and from here on to the spine it jumps. In spine, let me be very clear, any part can be involved, and in fact all parts of the spine get involved. This scenario starts from the lumbar spine going towards the cervical, but any part of the spine can be involved. Please be very clear. See, I taught you about rheumatoid arthritis last time, and I clearly told you that in rheumatoid arthritis, lumbar spine is never involved. It's only the cervical spine that is generally involved, but here any part of the spine can be involved, and sacroiliac joints is where the disease starts here at the sacroiliac joints. And even at the sacroiliac joints, let me tell you, it is the iliac side where the erosions come first. So it is in the ilium where the disease first starts. and then goes on to involve the peripheral joints, the spine and the peripheral joints. From the spine, even the peripheral joints can be involved, because that is how, a spondyloarthropathy classically presents. The peripheral joint involvement is almost seen in 1/3 cases. And in the peripheral joints, hip, shoulder, knee, elbow, almost that is the sequence. So it's hip that is frequently involved in ankylosing spondylitis if you talk of the peripheral joints, which can be involved in almost 1/3 of the cases. But 2/3 cases would be just limited to the axial skeleton, the sacroiliac joints and the spine. So that is the first point you need to know regarding the pattern of the joint involvement. The second thing you need to know, that this is a disease where classically you also tend to find enthesitis. Classical in patients, enthesitis. So what is enthesitis? I'll tell you. Inflammation at the attachment sites of the tendons, ligaments. So that is also very classical of this condition. This tendoachilles is attaching to heel, so it might be that this particular area could go painful. You can have ossifications at the attachment sites of the ligaments and the tendons. So when you see that predilection for the axial skeleton and the sacroiliac joint being the starting point, and when you see that this patient is having enthesitis at multiple places, that is where you start suspecting ankylosing spondylitis, and that is where you order this HLA-B27 that may be positive in almost more than 90% of the people with ankylosing spondylitis. Now, when someone comes to you with ankylosing spondylitis, the diagnosis can almost be, ascertained by this very nice modified New York criteria. Very simple. You find the radiological evidence of sacroiliitis, and you find this gentleman is clinically having low back stiffness, or he is having restriction of the chest expansion. So this is where you can suspect ankylosing spondylitis, and the moment you find this patient to be positive for HLA-B27, you can call this as ankylosing spondylitis. So that is how simple even the diagnostic criteria is. It's basically based upon those same things. You will have that thoracic spine involved, the spine part involved, so low back will be stiff, chest expansion will be low because there is spine involvement. So this is what is telling you that there is problem in the spine in this patient. The sacroiliitis is there. Okay, so sacroiliac joint is involved. The HLA-B27 is positive. So that is even by the New York criteria you tend to find that this is ankylosing spondylitis, making use of the same pattern. Now once you know it is ankylosing spondylitis, your job is to decide which part of the spine is involved. Is the sacroiliac joint involved or not involved? So all this needs to be found out. Now for involvement of the thoracic spine, you can just measure the chest expansion in this patient, and you find this chest expansion to be less than 5 centimeters at the level of the nipples. This is where you say the thoracic spine is involved. See, measure the chest circumference at the level of the nipples. Ask the person to breathe. The expansion is less than 5 centimeters. Thoracic spine is involved. To find the involvement of the cervical spine, you can perform this very simple Fletchy test. Ask the person to touch the neck and the buttocks in a single go. If the cervical spine is involved, the neck will bend forwards and you can't touch the two together. This choice here. If asked to touch against a wall, the patient will find it difficult to touch the head and buttocks simultaneously. This is correct. Okay. So this is not wrong. You were supposed to pick up the wrong choice. Clear? Because Fletchy test is going to be positive because the cervical spine might be involved. Now for lumbar spine involvement, we perform what we call as the modified Schober's test. That was asked to you in the question. So what I'm going to do, maybe this is the posterior superior iliac spine. In line with the PSIS, I mark a point on the vertebrae, and from this point I mark up another point here, and this distance you can imagine that maybe this is 10 centimeters. Now I will ask this patient to bend forwards. Okay. So this is my point at the level of PSIS, and this other point has gone here. So this point on the skin has moved farther because this patient has bent forward. So if you move forward, bend forwards, this point, this point, the distance between these 2 points is bound to increase. So I see the increase of this distance. Normally what you find here, in a normal person the excursion will be more than 10 centimeters. But if the lumbar spine is involved, like it could very well be the case here, the excursion will be found to be less than 10 centimeters, not more than 10 centimeters. So I hope that tells you how this is the answer, because this choice is incorrect in context of ankylosing spondylitis. So clear enough, guys? Even what is modified Schober's test with which you pick up lumbar spine involvement? And mind you, although spine can be involved, an area that is first involved is the sacroiliac joint. So I must also tell you the test with which you pick up sacroiliac joint involvement. So what has been shown in the first picture here is the Faber test. Some people also call it as like the Patrick test. What is shown over here, that's Gainsland's test. And what is shown in this picture down here is the pump handle test. So what you do in this Faber test, look at the position of this hip. The hip is in flexion, it's abducted, and look at this foot, it is externally rotated. So when you put this hip into this Faber position and you press this knee down, somewhere in the area of the sacroiliac joint here, back, the patient will complain of pain. This is Faber test. The better out of them all is actually the Gainsland test. So what you do in Gainsland, one side of the hip you extend and other side of the hip you flex. Now as you are extending this up, the patient might complain of pain in the area of the sacroiliac joint at the back. And this reproduction of the pain here tells you the Gainsland test is positive. And what you simply do in the pump handle test, you flex this knee till the chest. You flex the knee till the chest, and there's pain in the SI joint area, the pump handle test is positive. So these are the tests that stress the SI joint and reproduce the pain at the level of the sacroiliac joints. So these are the tests with which you can pick up the sacroiliac joint involvement and the spine involvement. So are you guys clear with it? Ritesh, Nishtha, would you be able to pick up whether SI joint or the spine is involved in case of ankylosing spondylitis or not by performing these very simple tests? Clear enough, clear enough. So can I have the thumbs up if you guys are clear with this? Now what you may find on x-rays or the imaging part in ankylosing spondylitis, well, as the name suggests, ankylosing, the joints will be fused. That could be one thing. Or you may find this calcification of these longitudinal ligaments, what classically gives you what you call as a bamboo spine appearance. Or what you may sometimes find is that this supraspinous ligament here at the back is calcified, and this particular X-ray sign, the interspinous, supraspinous, spinous ligaments being calcified, is what you refer to as the dagger sign. Yes, the dagger knife sign, the bamboo spine. Perfect enough, perfect enough. So these are the classical signs on the X-ray that tell you that you are dealing with this ankylosing spondylitis case. What you may see on the MRI, the Anderson lesions and the Romanus lesions. Romanus lesions are basically the shiny corners of the vertebra that are very nicely visible here. See these pictures. Look at the shiny corners of the vertebra. And Anderson lesions, they are basically lesions that signify spondylodiscitis. So see these disc areas inflamed. See these paradiscal areas inflamed. This is spondylodiscitis. That's classical of ankylosing spondylitis. So once you see these changes on the MRI, Romanus lesions, Anderson lesions, this is where you know this is ankylosing spondylitis. And when it is ankylosing spondylitis, the first line of choice what you have are NSAIDs. In the NSAIDs, indomethacin is the preferred NSAID. This is with which you can start your treatment up. Patient is not responding, you can add on the steroids. And yes, DMARDs are not very effective. Very few DMARDs have some role. In the DMARDs, sulfasalazine is what has maximum role. Otherwise, most of the patients have to be taken on the biologicals, the anti-TNF drugs to be specific. By and large, this remains the mainstay for most of the people because NSAIDs are not disease modifying, steroids are not disease modifying. To modify the disease, you all have the option of sulfasalazine, but that is too less a DMARD to modify the disease significantly. Okay, so you generally have to go to the biological DMARDs, not the synthetic ones. So anti-TNF drugs remain the mainstay in ankylosing spondylitis. So that's all about ankylosing spondylitis. A word about multifocal osteomyelitis. Multifocal osteomyelitis is associated with, alright, I'm sure you would have heard of this term also called multifocal osteomyelitis. This is something you know that we correlate with what we call as a Sapho syndrome. Sapho syndrome. I'll tell you what is Sapho syndrome. Actually, there was a term called chronic recurrent multifocal osteomyelitis that used to be very common. Okay, somewhere around the 1970s. That would denote an inflammatory bone disorder with some skin lesions. In 1987, the term was changed to Sapho syndrome. Sapho was this abbreviation, SAPHO, signifying some synovitis lesions involving joints, acne and pus, multiple abscesses on the skin, hyperostosis, thickening of the bones, and osteitis, inflammation in the bone that would simulate osteomyelitis. But this was not osteomyelitis because there were no sinuses, no pus, nothing draining. It was osteitis only, and no microorganisms could be identified. So it was essentially thought to be autoimmune only. And then it was multifocal, not symmetrical. So to date, we think it is autoimmune. Children and adolescents are involved, and treatment is supportive because the condition is generally self-limiting. So that's another form of maybe an inflammatory arthropathy, but as we'll understand it better, we'll be able to categorize it better. So that's all about this Sapho syndrome. And just one small question that was there in the NEET PG exam a little time back: dactylitis is associated with sickle cell anemia. That was the answer. Clear enough? And as I end up just showing you an X-ray of a case of hemophilia. In hemophilia also you can have arthropathy, and the classical signs: widening of the intercondylar notch and this epiphyseal overgrowth. Please, very important point, where you find epiphyseal overgrowth? Hemophilic arthropathy. So please do remember it up. With this, I am up with this session. Just a little bit of information on what we have for you on Unacademy. This is the batch snapshot. You can have a look. This is the plus test calendar. Book your dates in case you're wishing to prepare for the tests. I hope you know that we have full previous year question bank available on Unacademy, and this mock test is coming up very soon, 1st of May. So plan to give it to evaluate yourself before the upcoming NEET PG exam and the INICT exam. The new offerings we have on Unacademy for you, please have a look. So hope you enjoyed the session. Time for me to say bye bye to you. The referral code that you may use when you are subscribing to get your 10% off from my side, Ortho Life. You can use this referral code to subscribe. Otherwise, any doubt you have, you want to discuss later on, this is the Telegram group I run, t.me Dr. Mukul Ortho. This is how you can connect to me. So wish you all the best. Bye bye. Good night.